name is Beth Schlachter, and I'm Executive Director for FP2020. And we're deeply honored as the FP2020 community to have facilitated the development of the Ready to Save Lives Toolkit. It's preparedness for sexual and reproductive health in emergencies. This is part of FP2020's commitment to fostering collaboration among humanitarian and development actors. At the 2017 London Family Planning Summit, members of the Interagency Working Group for Reproductive Health in Crises, known to many as IWAG, insisted that a dialogue on scaling up access to contraception and services must include considerations of women living in humanitarian settings. IWAG called for partnership between humanitarian and development actors to ensure the fundamental right to family planning is available to people who are displaced by conflict, natural disasters, environmental degradation, and epidemics. Next slide, please. FP2020 heeded this call under the leadership of our beloved colleague, Jennifer Schlachter. Jen devoted her entire career to ensuring that women and girls in crisis situations have access to the best possible medical care, including family planning and other reproductive health care. She was a vital and beloved part of the FP2020 family and the IWAG community until her death last year. In honor of her mission to extend family planning to displaced people as a part of comprehensive sexual and reproductive health care, FP2020 continues to partner with governments, humanitarian and development actors around the world to raise the profile of and access to voluntary contraception everywhere. This toolkit was Jen's vision, to develop a resource that would link the sexual and reproductive health and humanitarian sectors to improve the health of women and girls in crisis settings. We're grateful to all of the sexual and reproductive health and emergency response experts who contributed their expertise to developing this toolkit. I also want to say a bit about Jen's spirit. It was this openness and this generosity and this seeing of people as individuals that inspired Jen's work and challenged all of us to approach our work differently, to think about the individuals and their need and the situations of their lives, and then to design programs and policies with that individual person in mind. We miss Jen very much, and we're really honored today that Jen's parents, Mary Jo and Ken Schlachter, have joined us, and they'd like to say a few words about Jen with all of us today. So thank you so much, Mary Jo and Ken, for joining us.
We'll keep it at a very few words, but I want to welcome all of you and thank you immensely. And I want to thank FP2020 in pursuing her vision so that it comes to fruition. And I want to thank you in advance for thank you for all of your work that you've already done. And thank you in advance for all the work that it's going to take to continue this work. We are honored and appreciative of all that you've done to maintain Jennifer's vision and Jennifer's memory. Thank you.
Thank you, Mary Jo. It's an honor to have you with us here as well. Working with Jen really was working with family, and so it means a lot to have you and Jen's sister Kendra here with us today as well. Thank you for joining us. You know, in the wake of Jen's death, taking this work forward became a labor of love for many. And I want to thank and acknowledge our colleagues at the UK Foreign and Commonwealth Development Office for the invaluable funding that they provided, but also for the many people who worked day in to make sure that this vision, this toolkit came to pass. And those are colleagues from International Planned Parenthood Foundation, John Snow Incorporated, the Women's Refugee Commission, UNFPA, and IWAG. We also remain deeply grateful to our colleagues at CARE for the funding of the original fellowship that brought Jen to FP2020 and helped us to build this partnership for humanitarian colleagues. So as countries around the world continue to deal with situations of displacement, as well as the COVID-19 pandemic, all of these complex emergencies mean that more people than ever have been displaced. And FP 2020 continues forging partnerships and fostering community commitments that ensure that the universal right to sexual and reproductive health and services is upheld. Although virtually for now, we join hand in hand with government ministers, civil society organizations, including women and youth-led organizations, humanitarian and development actors, and all funders to advance preparedness for sexual and reproductive health so that lives are saved during a time of crisis. It's now my great honor to introduce Dr. Natalia Kanem as our first speaker. As Executive Director of UNFPA, Natalia is an essential leader in the field of sexual and reproductive health and rights in emergencies and in development settings. Natalia is also the co-chair of FP 2020's reference group, overseeing and guiding our work over the last 3+ years. She brings to the position more than 30 years of strategic leadership experience in the field of medicine, public and reproductive health, peace, social justice, and philanthropy. So over to you, Dr. Kanem.
Thank you so much, Beth. Excellencies, Baroness Sugg, Mary Jo and Ken Schlachter and Kendra, distinguished guests, colleagues and friends. 2020 has been a year like no other, and we are indeed ready to save lives. Around 1 out of every 45 human beings in the world is estimated to be affected by a humanitarian crisis. And now we have a once-in-a-century global pandemic crisis exacerbating the tremendous toll of human suffering. The COVID-19 pandemic underscores a harsh, enduring reality, and that is that crises disproportionately affect women and girls around the world, and the world needs to respond. And to respond effectively, we need to prepare. We need to be ready to save lives. This Preparedness Toolkit for sexual and reproductive health care and emergencies is therefore vitally important. And as we meet more than 33,000 Ethiopian refugees have fled fighting in Tigray, crossing the border into Sudan, with thousands more arriving each day. The stories they've been telling speak to the unique challenges that women and girls face during times of emergency and the importance of preparedness. At our mobile clinic in Hamadayat, a woman said the following: "I can't afford to be pregnant right now. I have 3 children. We've had to walk 5 days to cross the border. When I found out contraceptives were available at the clinic, I was relieved." Another woman said that her 12-year-old daughter had had her first menstrual period during their harrowing journey. Quote, "I didn't have anything for her to use, not even a rag. I took out my only scarf and gave it to her. I cried so much. My daughter deserves better." Fortunately, preparedness in this case did mean that dignity kits were indeed available with sanitary pads and other personal hygiene items when they arrived. Sadly, however, another woman arrived at a healthcare center too late to deliver safely, and she lost her baby after 9 months of pregnancy. And unfortunately, she's not alone. Today, more than half of all maternal deaths take place in countries that are affected by humanitarian crises and fragility. And gender-based violence adds to the crisis, and it remains a shadow pandemic, a crisis within every crisis. And no woman should have to go through this. And this is the belief that unites us all. That's why we at UNFPA and all our partners, many of whom are here today, keep working steadily on the ground to ensure that life-saving sexual and reproductive health services can be available to everyone, everywhere. In the past 2 decades, humanitarian needs have grown so dramatically. Protracted conflicts are increasing preventable mortality, morbidity, displacement, and now we have climate change aggravating pandemics, everything compounding the risks of vulnerable, marginalized populations, and always especially the women and the girls. Sexual and reproductive health rights are essential. They're an essential component of any humanitarian response, yet still too often neglected. And now it's been 25 years since UNFPA and the Global Sexual and Reproductive Health and Humanitarian Partners co-founded IWAG, the Interagency Working Group on Reproductive Health in Crises, developing the groundbreaking and life-saving MISP, another acronym, the Minimum Initial Service Package for Reproductive Health in Crisis Situations. And this is why UNFPA Supplies, which is the world's largest provider of donated contraceptives, supports countries with the greatest needs to strengthen their supply chains so that women and adolescent girls can have a choice of contraceptives no matter where they live, even if they are in a crisis humanitarian setting. It's also why UNFPA, and we are the global custodian of the Interagency Emergency Reproductive Health Kits. We're working with partners, we're working with countries, with governments on the ground. This is so that women and girls affected by crises can have access to these life-saving sexual and reproductive health supplies, even during times of uncertainty. And it's thanks to years of this impactful fieldwork and advocacy. Many of you are here today, others are new, and it's great that this is intergenerational now, because this minimum initial services package, that MISP, is gaining wider acceptance as an essential element of humanitarian response, preparedness, recovery. That means respect for women and the biology of women, which doesn't stop during crisis. Still, let me admit, and I'll be the first to admit, that we have a long way to go to reach the furthest behind first, and indeed to leave no one behind. I worry about the increasingly protracted nature of humanitarian crisis today, crisis without end, that threatens the capacity of governments, of societies, of communities to respond and recover, causing long-term harm, damage to health and social protection systems. And COVID-19, again, is showing us that the lack of preparedness costs development gains. The lack of preparedness intensifies poverty and inequality, and we see this even in wealthier countries, far less in developing countries. And as a member of the Interagency Standing Committee and a signatory of the Grand Bargain, UNFPA is committed to advancing the new way of working towards collective outcomes across the humanitarian development peace nexus. It all fits together. As emergency preparedness work becomes increasingly prioritized across countries and contexts, we will continue working to ensure that sexual and reproductive health and rights issues are fully integrated. And it's through our leadership of the gender-based violence area of responsibility that UNFPA works around the clock with our partners to prevent violence and to protect the dignity and the health and the mental well-being of survivors. Dear friends, it was in fact a year ago when many of us joined with UNFPA and FP2020 and so many partners at the historic Nairobi Summit on ICPD 25. And in Kenya, governments, civil society organizations, businesses, foundations, and others, thousands strong, recommitted. We recommitted to realizing a world of sexual and reproductive health rights and choices for all in all settings. And among the commitments, and there were more than 1,250 of them, among these voluntary commitments, governments and partners have committed to preparedness and to improving the resilience of individuals and systems to ensure continuity of services during emergencies. And yes, the road ahead is more challenging with COVID, but we're scaling up our efforts. In September, a new high-level commission of advocates, experts, and advocates was established to make sure that we make progress towards these Nairobi commitments, that we stay on track. even with COVID-19, which no one foresaw the disruptions, right? But UNFPA will leverage our global platform, joining with others, as we are with FP 2020, to strengthen sexual and reproductive health preparedness. Our presence on the ground in over 150 countries before, during, and after crises enables national and local stakeholders, even before a crisis strikes, to get prepared. And that essentially means ensuring that women and youth-led grassroots organizations are meaningfully engaged. So this Ready to Save Lives Preparedness Toolkit is filling a critical gap, offering countries multiple options for proactive action to strengthen SRH preparedness systems. And as we develop our next strategic plan for the next 4 years at UNFPA, what we're working on is acceleration, scaling up to end unmet need for contraception, to prevent preventable maternal deaths, and to end gender-based violence. Our commitment is also to adapt based on what we're learning continually, and COVID-19 is teaching lessons, the megatrends of fragility, conflicts, climate change, and inequalities. And thirdly, accountability. We have to prove our results and deliver on the Nairobi commitments, on that ICPD program of action, and deliver like never before. I am very, very pleased to be together with you to celebrate this toolkit, which is part of the outstanding work and legacy of Jennifer Schlachter. It was her brainchild. Jen and her daughter, Baroness, it's true, were taken from us far too soon. And as we launch this fruit of Jen's labor, I extend on behalf of all of us at UNFPA our thanks to her family, her colleagues, her friends, and our profound gratitude for what she's led. I would also remind everyone that gender-based violence knows no borders. It can touch even those working hardest to end it, and we should extend support to all of the victims and families. Now, as we launch today, I also would like to highlight the contributions of FP 2020, the UK Foreign, Commonwealth and Development Office, the Interagency Working Group, the International Planned Parenthood Federation, John Snow, the Women's Refugee Commission, and so many others. We are really proud to have joined with you and for UNFPA to have had a part in realizing Jen's vision. Together, we move forward, we reaffirm our steadfast commitment to strengthening preparedness, to protecting and promoting the health, rights, and dignity of women and girls in every situation, including humanitarian crisis, and to ensure that promises made become promises kept. Our forward march continues. Rights, choices, dignity for all, nothing less. Adelante. Thank you very much.
Thank you so much, Dr. Kanem. You're always inspiring, and we're so grateful for your leadership and your work. Now my honor to introduce everyone to Lorelei Goodyear, who leads FP 2020's emergency preparedness work now. And it was due to Lorelei that we were able to take this work forward and finish it after we lost Jen. So thank you so much for your partnership, Lorelei. And thank you for this morning presenting the toolkit to all of us. Over to you.
Thank you, Beth, and thank you to Dr. Kanem for making such a powerful case for the importance of SRH preparedness. It's my pleasure today to provide a quick overview of the Ready to Save Lives Preparedness Toolkit. As mentioned previously, the IWAG has developed this standard set of interventions for delivery in an emergency called the MISP. The IWAG recommends that governments, agencies, and communities start to provide the MISP within 48 hours of the onset of an emergency. As process evaluations have shown, our MISP results are better when we take steps to become prepared in advance of a crisis. Our colleague Jen recognized both the critical need for preparedness and that many countries have valuable experience to share. She assembled a terrific team of partners, as mentioned before, IPPF, JSI, Women's Refugee Commission, and UNFPA, with support from the UK government to produce the toolkit. Next slide. The purpose of the Ready to Save Lives toolkit is to provide guidance, experience from a variety of settings, and resources to ensure that life-saving SRH services are available from the onset of any type of emergency response. The toolkit is intended for use by country-level decision makers and stakeholders from ministries of health and other ministries, national disaster management agencies, the private sector, civil society organizations, including those led by women, youth, and other marginalized groups, and international agencies that support their efforts. The toolkit guidance is based on a literature review and 80 key informant interviews conducted primarily by lead authors Anna Myers and Nesreen Talbi. It was reviewed by 35 sexual and reproductive health and emergency disaster management experts from around the world, to whom we are very grateful. Next slide. The toolkit outlines 3 stages of SRH preparedness. First, there's initiating awareness of the minimum standards for SRH in emergency. Nobody needs to figure out what is essential. It's already been outlined within the MISP. Secondly, assessing gaps, capacities, and opportunities in the local context, so you build on what capabilities already exist. And third, implementing preparedness actions based on the WHO Health and Emergency Risk Management Framework to systematically strengthen the health system to deliver quality health and related services before, during, and after emergencies, including SRH care. As we strive toward achievement of universal health coverage and the Sustainable Development Goals, preparedness is a form of insurance that our progress is not lost due to crisis. Next slide. The toolkit provides a rich collection of preparedness examples and lessons learned from a variety of countries and actors to inspire action. For instance, one of the briefs describes ways to be more inclusive of marginalized or underrepresented members of a community, such as women, adolescents, and older persons, people with disabilities, sex workers, people of diverse sexual orientations and gender identities, and those in migrant or refugee communities, all of whom have a right to respectful SRH care. Meaningful engagement of these groups before a crisis means that their needs are more likely to be met in a crisis. For instance, in Indonesia, dignity kits, as described by Dr. Kanem, were adapted based on consultation with older people, pregnant adolescents, and different religious groups. This type of upfront consultation makes it possible for us to better deliver what people need, not just to save their lives, but to uphold their dignity. Next slide. The toolkit also includes a curated collection of 45 different tools and guidance documents that can be used to launch or expand preparedness efforts. Next slide. To complement the Ready to Save Lives toolkit, the team of partners also produced 3 companion documents, a quick start guide version of the toolkit, both of which are available in English and French. The MISP readiness assessment was updated by IPPF, and JSI put together a tip sheet for starting continuity of operations planning for SRH supply chains. Next slide. Over the next year, next slide. Next slide. Over the next year, FP2020 and the partners who created these new tools will work with the IWAG sub-working group on emergency preparedness and resilience to conduct a series of webinars that will dive into more technical detail on these preparedness tools and others that are forthcoming. This working group of the IWAG welcomes new participants, and we'll put a link in the chat for those of you who are interested in joining us. The FP2020 partnership is going to continue into the next decade and will launch a new FP family planning commitment making process in January. For countries that are planning to make commitments to scaling up family planning and are convinced of the importance of preparedness for SRH, we at FP2020 and our partners are eager to support inclusion of sexual and reproductive health preparedness in new commitments by governments and non-state actors. Our hope is that all of you on the call today will refer to the Ready to Save Lives Toolkit as you make future commitments, as you work to strengthen your health systems, and as you update national emergency response plans to include preparedness for SRH. The launch of the toolkit is the beginning of the realization of Jen's vision. If you look at this image that's on the cover of the toolkit, it gives us an idea of where we go from here. This woman in Fiji is getting her health care needs met because somebody made a policy. Somebody created a budget line for preparedness. Somebody organized a training for this healthcare provider. And somebody pre-positioned supplies so that her needs could be met after a hurricane. Let's resolve today to be someone who is ready to save lives. Thank you very much. And back to you, Beth.
Thank you, Lorelei. We appreciate it. We're excited to launch this toolkit. We'll also be having some copies in print, so please do reach out to us if it would be helpful for you to have one, and we'd be happy to send them to you. Now it's my honor and my pleasure to introduce to you our colleague, Sandra Krause. Sandra is the Senior Director for Sexual and Reproductive Health Programs at the Women's Refugee Commission, an organization that's committed to improve the lives and protect the rights of women, children, and youth who are displaced by conflicts and crises. The Women's Refugee Commission is also where Jen worked for almost a decade, and so we're very happy to welcome Sandra Krause, and Sandra is going to introduce our panelists and moderate the panel from here forward. So Sandra, over to you.
Thank you so much, Beth. It's an honor to be part of this event and to moderate this esteemed panel. And I'd like to begin by extending a warm welcome to the Schlachter family and to all the participants today. I'm going to introduce three panelists who will each speak briefly for 5 minutes, but powerfully, I assure you, on their work on preparedness. And the first panelist is Dr. Grace Kodindo. Dr. Grace is an obstetrician gynecologist and currently the Deputy Director of Reproductive Health at the Ministry of Public Health and National Solidarity in Chad. She was awarded a Knight of the National Order of Civic Merit of Chad in 1997. She was also given an award from the International Federation of Gynecology, FIGO, and Columbia University's Faculty of Public Health for distinguished service in emergency obstetric care. So with that, I would like to, is Dr. Grace available?
Voilà, c'est ça. Comme vous l'avez dit, je suis gynécologue obstétricien au Tchad, mais j'ai également eu à travailler et particulièrement aussi bien avec Jen qu'avec Sandra Krause à MDD à l'Université Columbia pendant au moins 6-7 ans. Donc, c'est pour vous dire que je suis vraiment non seulement honorée, mais triste. Mais en même temps, je suis contente d'avoir participé à cette session qui honore la vie de Jennifer Schlachter parce que j'ai eu à beaucoup travailler pendant des années avec elle et elle a vraiment contribué à laisser sa marque dans le domaine de la santé de la reproduction en milieu de crise. Nous étions avec elle parlant de la même chose l'année dernière à Women Deliver à Vancouver au Canada. C'était la dernière fois que nous nous sommes rencontrés avec elle. Et pour vous dire combien c'est si important, c'est que, étant gynécologue, je sais que la mortalité maternelle au Tchad est encore la plus élevée dans le monde entier, parce qu'on a un taux de 860 pour 100 000 naissances vivantes. C'est peut-être les 2 ou 3 derniers taux dans le monde. Et vous voyez qu'en situation de crise, ça ne peut qu'être pire. Mais Dieu merci, comme nous savons que la stratégie d'intégration de la santé de la reproduction commence avec le DMI. En français, on dit le dispositif minimum d'urgence. Tout à l'heure, vous avez parlé de MISP. C'est la traduction du DMI. Et le Tchad s'est engagé dans cela avec beaucoup de partenaires ici au Tchad, que ce soit les agences des Nations Unies, les ONG, beaucoup de membres, beaucoup de ministères dans le gouvernement. Et nous avons un cluster qui est basé au ministère du Plan, qui coordonne toutes les activités, tous les effets quand il y a une crise ou quand il y a une catastrophe humanitaire. Et il y a 2 ans, nous en avons eu l'une après l'autre. Nous avons d'abord eu une catastrophe humanitaire, la sécheresse, qui a fait fuir les gens. Et après, un conflit armé est venu se greffer sur cette catastrophe naturelle, c'est-à-dire le combat avec Boko Haram. Donc, on a eu à utiliser la même stratégie. On a commencé effectivement avec le dispositif minimum dont vous avez parlé tout à l'heure, mais avec le cluster, nous avons également beaucoup des agences et chacun a sa particularité. Il y en a qui ont disposé des kits d'urgence, il y en a qui ont mis à la disposition des agences le personnel, parce que vous savez, nous manquons beaucoup de personnel. Et quand il fallait maintenant mettre en place le DMI, il manquait énormément de personnel. Donc, le gouvernement du Tchad a dû détacher beaucoup de sages-femmes, des infirmiers, des sages-femmes dans les régions qui étaient les plus touchées pour répondre rapidement aux besoins. Et ces mêmes personnels, après, on les a recrutés directement dans le gouvernement pour rester dans les zones justement qui manquent de personnel. Et pendant le Covid, il y a eu encore un sérieux problème parce que le personnel de santé était les premiers en ligne et c'était elles qui avaient été les victimes les plus nombreuses. Donc, on avait pas mal de cas de décès, même parmi les infirmiers, parmi les sages-femmes. Ce qui a montré le besoin qu'il fallait d'abord de s'attaquer au personnel de santé et aux formations sanitaires avec la formation pour la protection et la prévention des infections au niveau des formations sanitaires, la fourniture des équipements de protection individuelle pour les infirmiers et les sages-femmes. Parce que quand on voyait le nombre de décès augmenter au niveau des hôpitaux, les personnels de santé refusaient de venir à l'hôpital et même les femmes, les malades refusaient d'aller à l'hôpital pour les accouchements, pour la planification familiale et pour les services en général. Ils refusaient parce qu'ils voyaient que même le personnel était en train de mourir, donc eux, ils avaient encore plus peur. Alors, il fallait rapidement, donc, je crois, travailler dans ce domaine-là d'abord et ça a quand même permis après de prolonger un peu plus, en fait, rendre les formations sanitaires un peu plus sûres, quoi, pour que les gens puissent y arriver et surtout diminuer également la mortalité, non seulement parmi les patients, mais également parmi le personnel de santé. Et là aussi, le DMI était important parce que comme le personnel de santé fuyait les services de santé, il fallait rapidement augmenter les méthodes contraceptives qui étaient fournies massivement et gratuitement et pour attirer les femmes. Et les femmes, ce qui était merveilleux, c'est que les femmes ont continué à venir chercher leurs méthodes contraceptives, même quand les autres ne venaient pas. Donc, on a fait en sorte pour assurer la continuité des services de santé de la reproduction pendant même la crise la plus forte du mois de mars, avril, mai. On a fait en sorte que les services ont continué à exister. Les services de santé de la reproduction continuaient à exister. Mais au tout début, c'était difficile. Parce que d'abord, les gens ne voyaient pas trop l'urgence de mettre ces produits-là. Mais il fallait que les femmes venaient, on les a fait, ça a permis aussi de motiver un peu la hiérarchie et ça a permis également de faire. Nos agents, nos partenaires internationaux ont été formidables. Ils ont tout fait pour garantir que ces produits de la santé de la reproduction puissent être disponibles et ça a permis la continuité des services dans ce domaine-là. Je ne sais pas si j'ai fini mes 5 minutes, mais je suis prête à poser des questions s'il y en a.
Thank you so much, Dr. Grace, for that really compelling presentation of what's been done in chat. We're going to hold a question and answer session for later in this evening session.
D'accord.
Come a bit later, but we'll move on to our next presenter then. I'd like to introduce Ms. Patience Mgoli Mwale, who is the Learning and Advocacy Manager for Reproductive Health with Care International in Malawi, and is the National Civil Society Organization focal point for FP2020. She led the implementation of the standard of care known as the Minimum Initial Services Package for Sexual and Reproductive Health, and including family planning and pre-positioning of supplies in the wake of Cyclone Idai. With that, Patience, please feel free.
Good afternoon. Good afternoon. Can you hear me, Lorelei? Everybody?
Yes, very well.
Thank you. It's my pleasure really to be part of the panel in launching the Ready to Save Lives Toolkit and in honor of Jennifer Schlachter. It's, I met her last year when really I was getting to know more about the Minimum Initial Service Package. She was a lovely person, and I'm honored really to be part of those around the world continuing her work and resounding her voice and her genuine concern on emergencies and ensuring that we have SRH in emergencies. I will share the Malawi case on its journey to preparedness. When Hurricane Idai hit the country, UNFPA, CARE, and others leapt into action, but MISP was missing for preparedness plans, resulting in delays and SRH service disruption. SRH was not in Malawi's or CARE's emergency preparedness plan. It is not seen as a priority in emergency preparedness and focuses more on food, wash, and shelter, which is a natural instinct for survival anyway. But the experience with MISP has taught us otherwise. UNFPA responded, but more at central on the national level, as 15 districts were affected by the cyclone. At the district level, there was a gap in SRH services as most communities were cut off and were in camps. Even the healthcare providers were part of the survivors of that Idai. Humanitarian responders in camps had limited understanding of their role in GBV prevention or response and the MISP. And UNFPA had some preposition supplies, but not enough to meet the needs at the time, as the main port for shipment into the country, which is Beira in Mozambique, closed, so supply was disrupted. This meant rationing of existing SRH supplies in clinics, but survivors in the camps couldn't travel to those clinics as normal travel routes were cut. It took 2 months to get adequate SRH supplies and commodities into the country. Next slide, please. So within that, CARE stepped in to fill up the SRH service gap in Sandra district by providing MISP training to responders for healthcare workers, including the police, gender officers, and others. We did district level coordination, activated existing relationships with community-based gender champions to orient them on MISP and establish referrals for SRH, GBV, and SRH and gender-based violence services. CARE also shipped reproductive health kits from Dubai to Malawi to ensure continuity of services and essential supplies. Various camp communities and committees established working relationships with gender champions, whom we had trained on the MISP. And their role basically was to help referral for survivors, pregnant mothers, and also distribute the reproductive health supplies and also give feedback on gaps and needs and community level coordination. Next slide, please. Again, when COVID-19 hit, systems built during response to IDAI enabled some districts to quickly respond and sustain SRIH and gender-based violence services. Service disruption still was felt in other areas. That is, COVID-19 is a national and even global crisis. However, in the prepared districts, there were prepositioned supplies. They understood already about the MISP, so they were able to maintain essential SRH services. And also the SRH subclusters were immediately activated for coordination. More especially the reproductive health department knew what to do, at least with the experience, applying the experience from Cyclone Idai. A rapid gender analysis revealed gaps in SRIH, spikes in GBV, and this influenced the government of Malawi to prioritize the MISP nationally. This is to resound Dr. Kanem's words, a crisis within a crisis. Again, CARE mobilized existing partnerships with youth activists in monitoring of adolescent SRIHR gaps and barriers. The activated youth networks provide real-time feedback through WhatsApp, SMS, radio, and phoning in programs. CARE brought in this data into national and district level response conversations to adjust the services and addressed some of the gaps that were being identified. Next slide, please. Looking forward, hard hit by both IDAI and COVID-19, Malawi saw that there is an opportunity to build back resilient health systems that can withstand shocks and ensure MISP as a core element of emergency preparedness and response. The two crises have increased political will now to build more resilient health systems across all sectors. And also, you can see we managed to do an issues paper documenting increases in teenage pregnancies, child forced marriages, to help make the case on the need for SRH services within crisis. CARE certain that is the FP2020 CSO for Hopo in person and was part of the advocates. There is also ongoing advocacy efforts and trainings to build MISP into the national and district preparedness plans, including prepositioning of supplies, ensuring community engagement as well. And a joint, lastly, the last point I wanted to share is that there is a joint advocacy for domestic financing to invest in family planning. And with this, we've achieved an increase in funding for from domestic resources, and government was willing. Basically, the political will has been there. Thank you so much for the time, and that's what I wanted to share with you today.
Sandy, you're on mute.
I'm sorry, apologies. I clicked it, but it didn't quite come off. But I just was saying thank you so much, Patience, for your compelling presentation on the situation in Malawi and how critically important it is to ensure that health staff are trained in this minimum initial service package of priority life-saving services, and that they have the supplies and resources in advance to do that. It's really, I think, wonderful that you were able to apply the lessons learned from the cyclone to COVID-19. And so thank you very much. With that, I think I'll move on to introducing Dr. Syed Kamal Shah, who is the Chief Executive Officer of Rahnuma-Family Planning Association of Pakistan, which is a member association of International Planned Parenthood Federation. Dr. Shah worked for 19 years with the government of Pakistan and now has been working as a Chief Executive Officer with Rahnuma-Family Planning Association of Pakistan for the past 10 years. With that, Kamal, please.
Thank you so much. And I would also like to place on record our appreciation and gratitude to Jennifer Schlick for her wonderful work that she had been doing all her life, and the tribute launch of this toolkit in honor of her work that she has been doing. Now, what a wonderful person she was. I had met her a couple of times. If you could kindly go to the next slide. And the next one, please. This is kind of the format of my brief talking points that I would try to cover during my 5 to 7 minutes. And if we look at Pakistan, until 2004, there was no exact strategy for emergency response in Pakistan. And luckily, in the year 2004, again, the government of Punjab, actually, they launched Punjab Emergency Service. And under Punjab Emergency Service, they also launched Rescue 1122 services. Soon after the launch of this Punjab Emergency Services in the year 2005, Pakistan was hit by earthquake at a large scale. Just to give you a feel of at what scale, only in Azad Jammu and Kashmir, there were 40,000 pregnant women, as per media report, which were affected. And there were no safe delivery services available for them. And there has never been any data available on women and girls in need of SRH services. And the Punjab government was actually able, because they had already launched Punjab Emergency Service, and under it, they were able to shape up a quick response team. And that quick response team was actually able to respond to the concern. And based on this very experience of 2005, in the year 2006, National Disaster Management Ordinance was issued by Government of Pakistan. And then again in the year 2007, the National Disaster and Risk Management Framework was issued by Government of Pakistan, covering a period from 2007 to 2012. And again in 2010, Pakistan was hit by severe floods. And it was again at a scale of national level. And during this flood, as per media report, there were 500,000 pregnant women with no safe delivery services available to them. And again, there was no data available for women and girls in need of SRH services and young people in need of SRH services. And that was a time when we thought, because a Family Planning Association of Pakistan has been a pioneer of sexual reproductive health and family planning since we are the oldest NGO in Pakistan, and we thought that it is our moral responsibility to work with the government and partners and try to ensure MISP into disaster management protocols, because we saw that within the ordinance issued by Government of Pakistan, there was no reference to sexual reproductive health and family planning at all. And that brings me to my next point, the role played by Family Planning Association of Pakistan, and in partnership with UNFPA Pakistan, we were actually able to influence the policy. And if you could kindly take me to the next slide. And that was a strategy that we initially shaped, and we thought that we would target the federal government and the National Disaster Management Authority, and we would be able to have a win over there, and then it will be easy for us to work with every single provincial government and regional government and to lower district level. But things were not actually working the way we thought, and it was not really easy to approach the federal government and the national government and to make a case for ourselves. And we totally reversed our strategy. And instead of targeting the national government, we targeted the lowest level, because at the community level, there were people who were affected by floods and there were people who were affected by earthquake, and they became our spokesperson. And at the community level, it was much easier to make our case for better health and care for women and children during emergencies. And with those survivors, we were actually able to make a case at the district level, and within no time. And I must kind of highlight over here that we have had this intervention with financial support of the then DFID and now the UK and Commonwealth and Development Office, and in partnership with UNFPA Pakistan. And we have had win in 2012 at the district level, and with partnership with the district level and the CSOs working at that level, we were actually able to target the next level, which is the provincial level. And in the year 2012, again, in the same year, in the first quarter, we were able to get notification by one of the provinces, because as a strategy, we targeted only one province instead of targeting every single province, and we thought 50% of Pakistan is in Punjab, and we thought if we target one province, which is 50% of the country, we right away have had a 50% win. And within the same first quarter, we were able to get a notification issued by Provincial Disaster Management Authority of Punjab. And with that notification, we went to the rest of the provinces and to the regional government of Azad Jammu and Kashmir and Gilgit-Baltistan in Pakistan. And we were able within an year to get notification issued by every single provincial disaster management authority for inclusion of MISP in provincial disaster management protocols. If you could kindly take me to the next slide. So these are the notifications that were issued by every single, and it all happened in 1 year. And again, if you could kindly take me back to the previous slide and the first slide. And I would also like to remind that it is a key to decide and to see who are going to be your partners. And in Pakistan, UNFPA had been our key partners, and we are extremely thankful to the then country head of UNFPA Pakistan and the current country head, Ms. Lina Musa, and her wonderful team, Mr. Yilma and Dr. Jamil. They had been our partners, and we have had win. The next thing was to look out of the box, because there are usual partners, which is population welfare department, which is the health department, which is the social welfare department, disaster management authorities. But we thought in every single disaster, we thought armed forces are the very first one to respond to any disaster. And so far till then, we had not actually approached them. And we thought we need to be working with armed forces of Pakistan, and we need to train them on minimum initial service package. And with all those copies of all those notifications, we had made our case to the armed forces headquarters, and within no time we were called for a meeting, and we were able to convince the armed forces that if they are the very first one to respond in any emergencies, they need to be trained on MISP. And we were actually the very first NGO in Pakistan to train armed forces of Pakistan on MISP and all their service provider. And we actually got in writing an acknowledgement from the headquarters of armed forces that when earthquake happened in Nepal, the team that was sent by government of Pakistan to Nepal, all providers were actually trained by us. And this is what there was an acknowledgement shared with us by headquarters of armed forces that's why the response was very good, because everybody was trained on MISP right by us. So it is very important to target the right audience, to have the right partners while having strategies. And then we started making training every single partner on MISP, because it is a continuous process. You need to work at the community level, you need to work at the provincial level, you need to work at the national level, and to have the right partners and right audience and right stakeholders identified and working with them. And out of the unusual partners, we also targeted media, we targeted parliamentarians, we targeted young people, and we made our supporters within the young people, within the parliamentarians, within the media, within armed forces, within the normal stakeholders, which is the ministry concerned, which are the department concerned of the government. And we are still getting demands, continuous demand from every single partner for training them on MISP. And we are equally thankful to UNFPA Pakistan and also to AusAid, because Embassy of Australia and Pakistan, and we are thankful to His Excellence Ambassador of Australia and Pakistan. With their generous support, we continue to train all stakeholders and partners on MISP. How to ensure sustainability, and our understanding and our experience says that to ensure sustainability of the interventions, target the lowest level, because that's where we have had the first win. That's where the demand should keep coming, and the provincial government would act and the national government would act. And we, at the community level, we have been able to have resilience, community resilience, established reproductive health working group have been established, continuous meetings are being held. And they have, under resilience, I saw there was a question coming in the question answer in the chat box, whereby they were asking for resilience. So resilience is actually worked differently at different level. How to have resilience established at the community level, at the provincial level, and at the national level. And COVID-19 actually gave us all together new insights and learning into the disaster, because prior to, and I would quote it from Natalia as well, when she said that disaster of this scale, which gave us quite new learnings. We are not talking about a specific geographical area. We are not talking about a disaster which has a time span and a time period, but we are talking about something which occurs once in a while. And that gave, if there is time later on, I would come back to the COVID learnings and I would share. And if I would like to talk about today's preparedness in Pakistan. So we are covering the enabling environment. There are quite a number of components under it, and I would share a written note, and I would request the organizer to share it with anybody who would want to see that. And capacity building is a continuous process which needs to go on. Community resilience, there has to be a community resilience system in place to be able to respond to them. And repositioning of kit. Positioning and repositioning, whether it's dignity kit, whether it's clean delivery kit, whether it's a newborn kit. So all kits needs to be positioned. And this is kind of the latest framework of preparedness in Pakistan. Thank you so very much. And if there is time, I would come back to a couple of points as well. Thank you.
Voilà. Donc, avec le COVID-19, lors de la sensibilisation pour les DEMI, on a aussi fait, en même temps, on en a profité pour faire aussi la sensibilisation pour les services SR. Et ce n'était pas très facile au début parce que les gens ne comprenaient pas. Ils nous disaient que bon, maintenant qu'il y a le Covid, les gens sont en train de mourir. Pourquoi vous voulez nous parler encore de la planification familiale? Et quand on leur a fait comprendre effectivement que le problème est ensemble et qu'avec les DEMI, on peut aussi en même temps empêcher l'avenir des enfants pendant ces périodes très difficiles, et surtout que les services de santé étaient fuis. Donc, ça a quand même permis de faire la sensibilisation, aussi bien pour la PF et aussi bien pour le DEMI. Et le DEMI, il y avait déjà des produits qui étaient déjà préparés à l'avance. Et c'est ça qui a été très, très utile. Donc, ça a fait qu'on a pu éviter les ruptures de stock, surtout des contraceptifs, pendant cette période. Et les contraceptifs étaient gratuits, étaient disponibles. Et ça a encouragé les gens à continuer à venir demander les services. Donc, ça nous a permis d'assurer la continuité des services, ce qui a montré que les deux allaient ensemble. Et ça, c'était quand même un peu rare. Ça nous a quand même permis de faire ce travail-là. Et en plus, comme on a eu à le dire, pendant la COVID-19, les services étaient complètement désintégrés aussi à un moment donné, parce qu'à cause de ce problème d'infection et à cause de ce problème que les personnels de santé ont littéralement fui même. Mais quand on a réussi quand même à les former eux-mêmes et à leur fournir des équipements de protection individuelle, ça rétablit aussi la confiance dans les services. Ils savaient qu'ils n'étaient pas seuls, qu'il y avait des gens là qui s'occupaient de leur santé et de leur travail en leur fournissant des produits, des outils pour travailler. Ça a vraiment renforcé quand même la confiance des prestataires. Donc, on peut dire que ça a joué un rôle quand même positif. Bon, je ne souhaite pas que les catastrophes arrivent. Mais dans ce cas, on a tellement bien joué sur les deux que ça a apporté un rôle assez positif quand même, non seulement sur la maladie, mais sur le personnel de santé et sur la limitation des dégâts. Et surtout, ça a permis de continuer quand même les services, parce qu'on avait fait en même temps une étude au tout début, au mois d'avril, au mois de mai, on avait fait une étude avec l'UNFPA pour voir quel était l'impact justement de cela. Et ça nous a montré beaucoup de choses. Par exemple, ça a montré également qu'il y avait une augmentation de violences sexuelles. Le début de COVID-19, il y avait une augmentation de violences sexuelles. Il y avait les jeunes surtout, les adolescents, eux, ils étaient vraiment très résistants à ça parce qu'ils ne se croyaient pas, comme on parlait beaucoup plus de personnes âgées, et ils ne se croyaient pas du tout impliqués là-dedans. Et avec la sensibilisation, les jeunes également ont quand même commencé par comprendre qu'il n'y avait pas une limite, comme on le disait, que c'était eux, ils pouvaient très bien aussi être non seulement atteints de Covid, mais avoir en même temps des grossesses non désirées, non planifiées. Donc, ça a permis vraiment d'enrichir les outils de plaidoyer, de sensibilisation auprès de tout le monde, je peux dire. Et ça, c'était quand même des choses que nous avons apprises par cette étude-là, qui a apporté beaucoup d'éléments et qui nous a permis aussi de prévoir les éléments, surtout dans le sens de la sensibilisation et du plaidoyer. Je crois que si vous avez d'autres questions, je peux répondre à cela, quoi. Ça, c'était un peu le côté positif.
Thank you so much, Dr. Grace. I appreciate it. I guess we could, as long as you're with us still, and I haven't heard from the organizers yet, that we'll go forward. But would you want to expand a little bit more on the steps that have been taken in Chad to prepare to be able to deliver the SRH services in humanitarian crises?
Oui, le ministère, comme je l'avais dit, notre cluster est basé au niveau du ministère du Plan, qui évidemment, il coordonne non seulement les ministères, mais les ONG, les agences des Nations Unies. Et donc, il est un peu le bras droit du gouvernement pour pouvoir atteindre tout ce monde. Et je crois que la première chose que ça a permis d'abord de voir ça, c'est que les besoins étaient identifiés, étaient partagés, discutés, et les planifications, la programmation étaient faites ensemble. Donc, on a par exemple compris que c'était important que les services continuaient. Et là, il fallait maintenant, il manquait évidemment beaucoup de produits, il manquait des produits, donc il fallait acheter les médicaments, il fallait continuer à former les gens, non seulement dans la capitale. Au début, on a formé le personnel de santé dans les maternités, dans les centres de santé au niveau de la capitale. Mais après, on a étendu cette formation-là des sages-femmes, des médecins, des infirmiers dans les autres régions. On a 23 régions et on a pu atteindre une quinzaine de régions au Tchad où on a formé le personnel de santé dans la prévention et le contrôle des infections. Et on a également augmenté aussi les équipements de protection individuelle et autres, parce que là, il n'y en avait pas avant. Et c'était même pour ça que les infirmiers, les sages-femmes avaient été parmi les premières victimes. Et on a eu même pas mal de décès aussi parmi ce personnel-là. Donc, on a amené ça au niveau du pays. Voilà, merci. Merci.
Thanks so much, Dr. Grace. We just have a few more minutes, and I thought I would go to one of our other panelists to maybe speak to her experience. So this question is for patients, and wonder if you can speak to the situation in Malawi in terms of what difference it made to be prepared.
Okay.
And specifically around COVID. If you would like to.
Thank you. Yeah, just to go back to what I think some of what I shared. The COVID pandemic came with its own set of crises. And I mean, it's a crisis that was huge in proportion. And as a country, I think the immediate thing was, what do we do? How do we respond to COVID-19? When the government was trying to review, I think the major challenge has been, how do we allocate resources amongst the little resources that we have already? Our health systems were constrained in how we can respond to COVID-19. So within that, I think what mattered was, how do we look at where we're coming from and where we're going? It was a challenge really to have reproductive health services being put at the forefront, but it was easier having had the demonstrated case from Cyclone Idai, and I think it was still fresh in the government's memory, the Department of Disaster. And we were still like building on from the effects of the Cyclone Idai. So within that, you'd find that we've realized that prepositioning of supplies and having responders put in place, already prepositioned just to know when something happens, how do we reach out to them, and those supplies, how do we distribute quickly? My colleague, Dr. Said, said the prepositioning of supplies matters. Every other kit, don't underestimate its need. Prepositioning, it matters. And it was also easy for the reproductive health cluster to push for essential SRHR services, and the need to integrate, for the need for integration during the COVID with the understanding of MISP. The MISP, when you look at it, it's like minimal initial service package. Within that, it articulates the areas that we need to pay attention to. And within that, you'd find that there is integration, gender-based, attending to gender-based violence survivors, and also at the same time, there is reducing maternal neonatal deaths. There is reducing and preventing transmission of HIV within that. So those multiple issues that we're trying to understand and ensuring that there is continuity allows for integration of services, and also the response that would look at multiple layers of how do you respond to issues. So COVID, again, presented that bigger challenge, because I think when we're looking at COVID, immediately when it hit the country, there was that kind of pushback to say everybody was a suspect. You didn't have testing kits. How do I trust, more especially healthcare with the ones that were pushing back to say, how do I know that the person that I'm handling is okay? So that pushback. But eventually, when we quickly built in the systems, the integration was key to say, please understand the context of this, to say, you're not only treating COVID-19, but also a woman who needs the reproductive health services. And also another key aspect was the coordination. The sub-cluster had really various players coming into the cluster, just to understand how they can respond at multiple levels. At national level, who does what? At district level, who does what? And also I articulated more on the community level, the need to link up with the youth networks. Everybody had a role. The gender champions, they came in with their evidence, with their identifying gaps at a community level. So that alone helped us quickly respond to issues and see what can be done and what we need to take forward. Thank you.
Excuse me, Patience. Thank you so much for that really thoughtful response and all it covered. I think we are at time now, and I will turn this back to Beth Schlachter.
Thank you so much, Sandra, and thank you so much to all of our panelists. This really shows the global scope of our work on preparedness, and I know many of us have been saying since COVID struck, and Dr. Kanem mentioned this as well, that it really highlights that if you're not prepared for a crisis, then you're really not doing your work ahead of time, because crisis will hit, whether it's from a natural disaster, a global pandemic, or perhaps violence in communities and in countries. And so we owe it to each other, to ourselves, and to our families to be prepared for that. So with this, it's my great honor now to introduce all of you to Baroness Sugg. Baroness Sugg has been a minister at the Foreign and Commonwealth Development Office since September of 2020. And Baroness Sugg's ministerial portfolio includes gender equality, sexual and reproductive health and rights, children, youth and education, and inclusive societies. And again, we remain deeply grateful to the UK government and the people of the United Kingdom for providing the resources for this toolkit. So Baroness Sugg, over to you.
Thank you so much, Beth, and thank you everyone for your really important contributions today. I wanted to start by reflecting on the 2017 Family Planning Summit in London, which really was a pivotal moment where the needs of women and girls in crises were firmly put on the global family planning agenda. And we saw significant commitments made by countries and donors and civil society to address what we all know, that women and girls need access to sexual and reproductive health services in crises, and in fact it may be when they need it most. And we acknowledge that it's possible to deliver SRH services in these settings, and we heeded the call from women and girls themselves that they want these services. But we would not have achieved such success without Jen Schlecht. And Jen was pivotal in the humanitarian working group for the summit. She represented the interagency working group on reproductive health in crises. And with that, she passionately and skillfully represented the community and built on the years of hard work by many of you who are attending the meeting today. Jen then played a leading role on humanitarian preparedness and response at the FP2020 Secretariat. And I'm really privileged to be here today to help launch this Preparedness Toolkit, which we supported with UK aid. It feels like a really appropriate way to honour Jen's memory and to mark such an important milestone in achieving what we all set out to do in 2017. And it's really wonderful that her family are here today. COVID-19 have shown us many things. It's particularly that we've got to do better to prepare for crises. And Natalia described really well the human cost of crises, which are at an all-time high. We know that we need funding to be able to keep pace with those needs, and we know that the funding we need isn't available. And with these constraints, we can't afford to be unprepared for crises in the future. On average, every $1 invested in emergency preparedness, we can save $2.60 for the next crisis. So the way we approach crises needs a systematic change towards greater preparedness, anticipatory approaches, and resilience programming. And for far too long, sexual and reproductive health has not been prioritised in normal times and in crises. And as we all know, that can really have terrible ramifications for women, girls and their families, particularly when they're at the most vulnerable. And where country health systems are weak in normal times, the policies and the budget allocations, the workforce capacity and commodity supplies, it's really a tall order to expect a fast and comprehensive sexual and reproductive health response at a time of crisis. So it's better to have upfront thinking about the preparedness of SRHR services and how they can make a really big difference to an emergency response. And the toolkit outlines how we must continue to prioritise, safeguard and invest in sexual and reproductive health, including as part of health system strengthening and UHC. A really good example of UK support in this area is our £425 million UNFPA supplies programme, which I'm incredibly proud of. Through a new operating model next year, that's going to help drive an increased focus on strengthening countries' supply system preparedness and response. And as we improve preparedness, we can't ignore the key role of local actors, including, of course, women's rights organisations. They are the constant presence with local relationships, skills and expertise and the first responders, and investing in their capacity in a truly sustainable way is good preparedness. The UK supports a range of mechanisms that reach local actors, but we know that this area remains underfunded, and the FCDO, my department, is therefore working to make sure that we're building our support to women's rights organisations, including through new efforts we hope to start next year. So COVID-19 has really laid bare many of the challenges we have long been grappling with, but it has offered some opportunities to build systems. For example, in Mozambique, family planning was categorised by the government as an essential service early on. And that meant that our flagship programme, WISH, was able to continue services and nearly tripled its quarterly target. And in South Sudan and Somalia, our WISH partner, the International Rescue Committee, has already been training service providers in the MISP. And this enabled the continuation of services in the pandemic, and they actually saw a 25% increase in services access to services between July and September across both countries. And during this crisis, we're witnessing more remote care, self-care, task shifting, supply chain strengthening and policy changes. And these measures I really hope will leave many countries in a stronger position if they experience future disasters. And looking ahead, as FP2020 in its current form draws to a close, we've been shaping the next phase of the Global Family Planning Partnership, which will launch next year. And we know that strong systems and humanitarian preparedness and response will be really central. And we hope that country leadership can grow in those areas. We've seen the difference that country commitments to make. At the 2017 summit, Bangladesh made the most comprehensive commitments to family planning and emergencies, and significant strides to be made to deliver them. And there's still major challenges. The Rohingya refugee crisis is one of the strongest examples of sexual and reproductive health being integrated from the outset of a response. So I am hopeful and helpful about what can be achieved. And this toolkit really plays an important part in that journey. I really want to thank Beth and Lorelei and the FP2020 team for your continued work and your incredible commitment. And of course, thank you to Natalia for your leadership and for UNFPA's critical work in this area. The UK continues to be a fierce champion for the rights of women, girls and marginalised populations affected by crises. And we stand with you as we work together to really ensure that they can access the sexual and reproductive health services that they need, that they want and what they deserve. Thank you.
Thank you, Baroness Sugg, and thank you, Natalia, as well. It's been a very rich morning in conversation, and I'd like to leave everybody with some thoughts about next steps that we might take together in the months and the years to come. I encourage governments, government officials, humanitarian and development actors, and civil society organizations representing crisis-affected populations to come together to make strong commitments to building country and subnational preparedness and resilience plans and capacities. We'll be launching our toolkit for the 2030 commitments formally in January, and we look forward to partnering with all of you with that critical work. As Baroness Sugg mentioned, We're working intensively to craft the next iteration of our family planning partnership for the decade to come, and we'll be working on that throughout 2021, and we look forward to everyone's partnership in that endeavor. So you can also go to the FP2020 website now to access the Ready to Save Lives Toolkit, where you will also have a chance to learn from other countries' experiences and consider taking the recommended preparedness steps. You can also consider joining the IWAG Emergency Preparedness and Resilience Sub-Working Group to share your experience and learn from others. There was also a question in the Q&A about how family planning practitioners are working together with others, particularly in the GBV sector, to bring these efforts together. And it's really through the IWAG sub-working groups that we hope to take that work forward as well. We also want you to consider please sharing your preparedness experiences during meetings and consultations next year, including the International Conference on Family Planning. We'll be having a session in February, and then again, we hope, in person in November in 2021. We know the IWAG is also working to have their scheduled meeting in 2021 as well. So continuing to learn from each other is an important opportunity. And if FP 2020 has taught us, or 2020 has taught us anything, it's that it's never too early for health systems to incorporate preparedness for sexual and reproductive health. Effective crisis response depends on building preparedness into sexual and reproductive health and health system strengthening efforts. And the Ready to Save Lives Toolkit gives us a roadmap for steps that we can take together. Being prepared will save lives, save resources, and maintain the development gains we've already made on our march toward the achievement of the Sustainable Development Goals. Next slide, please. So I'd like to thank all of our speakers sincerely. Dr. Kanem and Baroness Sugg for making the case for preparedness as a life-saving and cost-effective, and to Lorelei for previewing the toolkit today. We're grateful to the UK Foreign, Commonwealth and Development Office for their financial support for this toolkit. I'd like to thank Dr. Grace Kodindo, Ms. Patience Mgoli Mwale, Dr. Saeed Kamal Shah, and Ms. Sandra Krause for such a stimulating discussion of experiences from countries in conflict and countries coping with natural disasters, and for offering your perspectives as government officials and NGOs. I appreciate that you shared your insights on your challenges and successes, and I look forward to our continued partnership with you and your colleagues on emergency preparedness and resilience efforts for sexual and reproductive health. And my heartfelt appreciation to our longstanding partners at IPPF, JSI, Women's Refugee Commission, and UNFPA, without whom we could not have completed this ambitious effort. You were thought partners to Jen, friends to Jen, and after her death, you dug deep and found the strength to see this project through to completion. So today we celebrate your dedication as well. I also want to thank the Schlachter family for being with us today. I know it meant a lot to all of us. You have colleagues and friends here of Jen who worked with her in countries around the world, Pakistan, Chad, Malawi, and so many others who are speaking today. So we want you to know how much we loved and appreciated working with Jen, how much we learned from all of her, and I hope that you feel how inspired we all were to be her friend and her colleague. And we hope that we can share that we've shared that with you today as well. So finally, I'll just say that the content of the toolkit was developed with the generous contributions of time and insight from more than 80 government, humanitarian, and development actors from around the globe. We're grateful to the 35 sexual and reproductive health and emergency and disaster management experts who reviewed the toolkit, especially since they made time to provide thoughtful comments while responding to the COVID-19 pandemic. These dedicated professionals are paving the way for other actors to strengthen their own health systems to be able to robustly respond to all types of emergencies and meet the sexual and reproductive health needs of crisis-affected populations. So thank you everybody for being with us today. Thank you for your partnership, and we look forward to working with you through the end of this year and in the decade ahead. Please stay safe, take care of one another. For those here in the United States, I wish you a happy Thanksgiving. It's the best of holidays because it's just an opportunity to give thanks to the things in our lives that are the most meaningful. From FP 2020, we give thanks to all of our partners. Be safe, and we'll see you again soon. Bye-bye.